Dr. Emami is a post-doctoral fellow at the University of Pittsburgh Medical Center Sports Medicine Concussion Program. We're grateful to have him here to present the lunch lecture titled Evidence-Based Evaluation and Management of Sports-Related Concussion. Welcome.
Thank you. I haven't done anything yet, thank you. Thank you, Kaylin and Emma. You guys have been awesome with the communication and setting this whole thing up. I actually made a comment to my boss and supervisor how organized this whole thing has been, so appreciate it for setting all this, and I know it's a lot of work, although I've never done this, but it's a lot of work I could see. So I'm a postdoctoral neuropsych fellow at UPMC out in Pittsburgh. Work in a specific concussion clinic where you see over, almost 17,000 patients a year from all around the country. I just really quickly don't have any disclosures or financial interest in anything here. I am a lowly fellow. And so this is just a quick thing about our program. About 17,000 patients roughly. This is a couple of years old, so it might be a little updated now. Patients from all around the country. You see pro athletes up and all the way down to little kids. The youngest I've seen, and I think I've actually seen like a 5-year-old, all the way up to 70 plus. Across different sports, different mechanisms of injuries, we see trauma, car accidents, everything. So it's pretty comprehensive and pretty busy. So just really quick, the objectives of this talk. I'm just going to quickly, we've done the pathophys, so I'll probably just blow by this really quick. Signs and symptoms of concussion, we've done this as well, so I'll probably just go through that pretty quickly. Some on-field management and some post-acute outpatient stuff, so this is kind of when we see them once they've been evaluated on the sidelines and whatnot. And then some targeted clinical trajectories and some treatment options for concussion. And then some about recovery rates and some risk factors. And then if I have some time, I'm going to present a case, and I have some video and stuff like that about the case. So, all right, pathophys, we talked about this. It's kind of a metabolic issue at the cellular level. Forces transmitted to the head or brain cause this kind of ionic shift at the cell level. And that's kind of what produces the concussion symptoms. And at the same time, we have this kind of like vasoconstriction and blood supply to the brain. So there's this like mismatch between energy supply and demand, and that's kind of what leads to concussion symptoms. This is a quick kind of schematic that we have. So it's important to note that metabolic dysfunction can exist in patients with kind of normal Glasgow Coma Scale scores. And the pathophys stuff can be kind of effective for weeks. We've seen that kind of the diagram of that earlier. Some signs and symptoms of the injury. Signs are loss of consciousness, PTA and anterograde, amnesia, disorientation and confusion. And it's also important to know, we have, during football season, we have Saturday clinics, so we see patients kind of literally less than 24 hours out. And we always tell them, like, what you feel now is, maybe different than what you feel 24 to 48 hours. So just, be aware of what can happen. We always give a disclosure that if your mental status, you start vomiting, all the big signs that need immediate medical care, we kind of give them a heads up on that just so everyone is on the same page. But this thing can kind of fluctuate in the first 24 to 48 hours. And also, as we've talked about this before, you don't necessarily have to have loss of consciousness or these big hallmark signs to have a diagnosis of concussion or have the symptoms that come with concussion. These are just a list of symptoms, a study done by Anthony Contos. He's the research coordinator in our program. Just a breakdown of the common symptoms, headache being reported in 75% of people that we saw, concentration difficulties, fatigue, drowsiness, and so on and so forth. So SIDELINE assessment, this is kind of, I don't play a role in this. This is more like the orthopedic doctors, neurosurgeons, athletic trainers for kind of the high school and college level. And usually, I've seen talks by them as well. If they suspect anything, you are pulled and you're not going back. They're taking a little bit more of a cautious approach. So even if there's a presence of any on-field finding, they're going to err on the side of caution and pull you and keep you out. There have been times where I have seen people in clinic where they've been pulled, evaluated, and there's definitely been signs, and one kid told me that he vomited in the locker room and the coach put him back in the game. He was a football player, and I was like all up in arms about it. I was about to call the athletic trainer and tell him that that's not cool.
So what you said, so this is you're talking about the Pitt football team?
No, this is just like a high school level athlete, yeah.
I doubt the Pitt
Oh,
football
no,
team would,
yeah. No, it was a high school football. Yeah. It was a high school football player. So they're going to do kind of evaluation to make sure there's no other serious neurological or cervical spine injury. They'll make a referral to the ER most often just to rule out brain bleed or anything like that. They'll do a quick mental status testing, kind of like the SCAT that we went over, and possible exertion testing. That's very rare to do that kind of right away. And then this kind of leads us to kind of better manage the patient, not lead to more longer recovery times and all that stuff you hear about second impact syndrome and less biomechanical force leading to more serious injury. This kind of prevents that more catastrophic outcome from if you could just identify it right away, pull them, get them out, and then have them come see somebody
Anyone
afterwards.
wants to look at the SCAT, I printed one out.
Okay. Yeah, you could pass it out. Yeah. So this is just a slide that kind of that talks about this. This is a research study done by Dr. Elvin. I think he was a former research fellow of our program, and some other people are associated. So they compared the recovery times of athletes ages 12 to 19 who are either immediately removed from play and those who remained in play following their injury. This does not mean that they sustained another injury, but they just kept playing. So athletes, they played a variety of sports, and the results show that if you even remain in play, the average recovery time was 44 days, while those who were pulled right away are about 22. So this kind of doubles your recovery times. And then a former fellow of our program who left last year, he's working on a manuscript to see if there's a dose response effect. So does 0 to 0, if you either removed right away 0 to 15 minutes of extra play or 15 minutes and greater, does that change your recovery times? So he has not published this yet, but these were the findings that he found. So those who were immediately removed from play, on average took about 18, almost 19 days, and then those 15 or fewer minutes, 28 days, and then the 15 plus were 44 days. So you kind of see this little uptick and stuff. Any questions with that so far? Okay. So is concussion a treatable injury? I'm more on the treatment side of things, the evaluation, the clinical end. So this is I feel like the paradigm has kind of shifted to actually being very active and kind of helping patients out rather than doing the rest model of dark room, don't do anything, sleep in a bed, don't move at all. And this was just a conference that was held at UPMC, trying to come up with some agreement statements across various different leading experts in the field, neuropsych, neurology, neurosurgery, sports medicine, PM&R, so on and so forth. And the first statement that was addressed was in regards to more traditional long-held beliefs that rest is the only way to manage. And like I said, this has kind of fallen out of favor in recent years, and this was their response. And I've read some stuff that it actually will kind of take people longer when they do that strict rest stuff. This is the next question. And initially, I know concussion was thought about this as like this homogeneous injury, this one thing that's happening, but over time we're trying to think of it as an injury that can present in multiple different ways and different types of injuries and different symptoms that can have different profiles, and that's kind of how we conceptualize injury when people come to see us, and I'll kind of go through that really quickly in a couple slides. But this is just a response from that kind of thing that characterizes that it is like a multifaceted injury. And then as far as the treatment standpoint goes, trying to find actually the right treatment to match the right problem. That's kind of how a lot of medicine and other fields kind of have illness. You come in with a cold, this is what we're going to give you, or so on and so forth. So that's a response for that. And then overall, concussion is treatable, and one person abstained. I don't know who that was. All right. So this is the outpatient concussion management. So this is like what I do on a day-to-day basis when I see somebody. So some athlete comes in, we do first go through kind of a detailed clinical interview. To me, this is probably one of the most powerful things that we do. I use it as a kind of a data gathering exercise, get some information about the specifics, the mechanism of injury. Sometimes there are questionable mechanisms of injury that we see. I saw somebody say they got hit in the head with an empty water bottle and they're coming in and they're having blowout symptoms, so that's a whole nother, but when it comes to sports, we review kind of the mechanism and what happened, what did they feel initially, what happened, did they keep playing, did they lost in consciousness, all that stuff. And then kind of go through their biopsychosocial history, get a detailed kind of medical history of them and their family, mental health history, migraine history. There's a history, some research that shows a history of car sickness can lead to some issues. I have some slides on that. And then I use this as a time to kind of really build rapport with the athlete, because as we've seen in previous talks just today about the hesitancy for an athlete to kind of disclose symptoms. I played basketball. I know exactly how this is. I had a concussion in a game, and if my mom wasn't on that sideline and came and pulled me out, I would have been perfectly fine to keep playing. So you have to understand the mentality of an athlete and kind of what goes into why they wouldn't tell somebody, right? There's a whole host of stuff. You don't want to miss playing time. If you're on a fringe player on a team, you don't want to get cut. You don't want to let your teammates down, so on and so forth. Then we have a vestibular-ocular screener. I'll kind of quickly go through that and give you some more detail in a little bit. Do some computerized neurocognitive testing, and at times we will refer them for like an exertion eval. We have a pretty lucky to work here because we have a good team of people that we can just send them downstairs and have them see one of our physical therapists. And the goals of this evaluation are to kind of establish diagnosis and prognosis, establish the clinical profiles that I'll go over in a little bit, and then kind of come up with a treatment plan, recommendations. If it's a student, they need some accommodations to help them out at school, we'll kind of provide it at that point. And then kind of plan. I kind of hesitate to give firm recovery times because I don't know what's going to happen, but athletes will occasionally ask me. I give them the general roughly 2 to 4 weeks, but I always say I've seen kids come back in a week, they say they feel fine. I've seen kids take about 6 months and they still kind of struggle. So there's a huge range of what we see. And effective communication and treatment plan goes a long way. Kind of earlier, that comment I made about knowledge is power here. If you kind of let the athlete know why they feel what they're feeling, I feel that goes a long way for them to kind of know that there's an actual reason, there's actually like a physical reason that's going on. And we give this to everybody. It's very important to kind of regulate usual behaviors and day-to-day functioning things. With a lot of the chronic cases that we see that come years on out, they've been, lack of hydration, they're sleeping 12 hours a day, so on and so forth. They're completely dysregulated. So our first kind of plan of action is going to get you on a regular, day-to-day cycle. This comes kind of from the headache literature, actually. This is general headache 101 for people with migraines. So you want to regular diet, breakfast, lunch, dinner, hydration. I always say 60 to 80 ounces. I always modify that if I'm seeing a 5-year-old, it would probably kill them. Regulate sleep schedule, kind of pick a bedtime and a wake up time. We kind of discourage naps just because that throws off their sleep later on at night. But if naps are kind of a normal thing that you do, that's usually fine. And this is kind of after 48 hours. If we see them kind of immediately, we're a little bit more lax. We understand that the fatigue and all that stuff. So, but after that, if they come a week later, we kind of harp on this pretty quick. And then we take a very active approach to things. We have them kind of exercising. We encourage exercise after the first kind of visit. Sometimes patients are just like, wait, what? Really? I can actually do something? Obviously, we have guidelines, they're not allowed to play sports, no contact, so on and so forth. We usually start off with kind of a light stationary bike and kind of progress them. A lot of the teams have athletic trainers and they kind of manage the exercise piece of it going on, and then we'll evaluate them going forward to see how they respond. And then stress management, which is a huge part of what we see, is that can often exacerbate symptoms. Any questions before I go into this? Yeah.
I think the VOMS is incredibly cool.
I think VOMS is incredibly cool, and I wish that the variety of eye doctors that are out there could provide that service, because it's really hard in general communities to find somebody that will understand what that means and the value of it.
Yeah, and you mentioned that convergence issue with your son. My case is actually going to be a convergence case, so we see that a lot. And that's something that we see, that people come back and their eyes aren't working together and they're having headaches and all that stuff. So, so the VOMS was developed by some of the PT people in our program. It's a 5-minute exam where they self-report their symptoms for each of the following portions on the VOMS. I'll show you the form in the next slide. On a 0 to 10 scale, 0 being no symptoms at all, 10 being the worst possible severity of the symptom. And we detect positive sign of dysfunction with that issue with a +2 report on any of those VOMS measures. And the components are smooth pursuits, horizontal, vertical saccades, vestibular-ocular reflex, visual motion sensitivity, and near point of convergence. And I'll go through each one. So this is the form that we use. See if I get a pointer here. So they're going to rate their headache at baseline. So when they come in, 0 to 10 across headache, dizzy, nausea, and fogginess. And then after each administration of the VOMS, we kind of stop and ask them to see where they fall on that severity scale. So smooth pursuits is the first part of this. It tests the ability of the patient to follow a slowly moving target. So you're going to sit about kind of 3 feet from the patient. I'm going to have them kind of follow my finger 1.5 feet to the right, up and down, and come back to the other side, up and down. I'm going to go through 2 or 3 repetitions of this just to see how. I don't expect a lot of symptom provocation from this, but I'm trying to track their eyes to see if they're following my finger correctly or their eyes are kind of jumpy and staggery going across. That's a whole different kind of issue. Horizontal and vertical saccades, again, 3 feet from the patient. I'm going to put 1.5 feet from the midline on both sides. I'm going to have them look back and forth at each of my fingers as quickly as they can for about 10 repetitions. And again, I want to see how quickly their eyes kind of move. I do that horizontally and vertically. A lot of patients that have issues with saccadic eye movements will report issues in class and school and kind of scrolling. If they're kind of like going through a computer and kind of scrolling through things, their eyes won't really kind of keep up with what's going on. So they will complain of a lot of like visual difficulties and all that. And near point of convergence, this is the test the ability of the eyes to turn inward to focus on a near target. So usually have like a popsicle stick that has a 14-point font, either a letter or a dot, and I stand and I bring that stick closer and I have them cross their eyes. And I want the patient to tell me when they see double of that object on that stick, or if I know, sometimes you'll see, the first time I saw this, I was like, could not believe I saw this happen. But so it was like my second day of fellowship, and so you come down and then right where they see double, you'll see one of their eyes, if there is a problem with this, kind of shoot out. So it's like the eye becomes lazy. So that energy problem is not allowing the eyes to kind of converge on a target. And this is, in the case that I have, kind of highlights this kind of problem and what can result from that. So patients often, people with a convergence issue report kind of frontally based headaches, eye pressure, fatigue, difficulty with like math and kind of visually demanding tasks and computer work and all that stuff. And then the vestibular-ocular reflex, or we call VOR, tests the ability to maintain focus on a stationary object while moving your head without blurriness or dizziness. So I use their thumb, you can use the stick, and you have the patient kind of move their head side to side at 180 beats per minute. We sometimes will use a metronome to actually kind of get a good assessment of what 180 beats per minute is, because a lot of people come in and they just do this, and I'm like, yeah, you gotta give me more than that because I'm not getting anything out of that. So it is uncomfortable, and I try to be as nice as I can, but I'm trying to get an accurate assessment. We do kind of encourage them to kind of give us an adequate effort with that, even if it is really bothersome to them, just so we have a good read of what's going on. And then we also do it in the up and down vertical plane. And then the last portion of this is visual motion sensitivity. So it's the ability to inhibit vestibular-induced eye movements. So again, I have a patient out here, put their thumb out and rotate at the trunk, kind of side to side, while they're staring at their thumb. to kind of see how they tolerate. A lot of patients that have these kind of issues also report difficulty on like car rides and really like visually demanding tasks day to day. So that's the VOMS. And then they report, like I said, headache, dizziness, nausea, fogginess across after each one of these components. And if it's a +2 jump, then it indicates to us that, you know, they need further evaluation. We'll make a referral to a vestibular therapist that we have, and they'll do a more higher level thing to see if they actually need treatment. And there is actual treatments that have been developed to kind of help retrain these parts of the brain. Yeah.
So I get excited to ask the question too.
Sure.
Like VOMS. Are you working to train pediatricians in this and eye doctors, or do you still feel that VOMS is something that needs to be embedded in a concussion clinic, or can it get pushed out? I remember Dr. Collins presenting on it 2 or 3 years ago
Yeah.
when the paper first came out at
Yeah.
Harvard, and you know, it was hoped then that it
It would spread.
could be, but I think it's such a valuable
Yeah.
tool. But who do you think is best picked to use it?
I know almost all the athletic trainers that we work with use it on the sideline after. We've been baseline VOMsing people before the season. I did some for some of the colleges. But as far as the pediatricians go, I haven't seen it. Like when I look at a medical chart, I don't see them VOMsing anybody. Some of the ophthalmologists, actually some ER docs, some ER ophthalmologists have done it, and I was shocked to read it. So it is kind of getting out there, but it is still fairly slow from what I've seen. But
It's not anything you guys are running trainings in.
not that I'm pretty sure they are, but not that I can't give you a definite answer, but I can't imagine that they haven't really. So
So just to follow up on
Yeah.
Catherine's point there, would you say, you know, like because SCAT was always for medical personnel, then they released the CRT5 so lay people can use it. Do you ever think we get to a stage where, just coming from an Irish perspective, we don't have anyone on the sidelines for about 95% of activity? So do you think there would ever be somewhere down the line where there could be training courses for lay people to do VOMs, not for diagnostic purposes, but just to give some more objective data? Or are we getting a little bit too complicated? Because I'm just looking, because financially
Yeah.
speaking, it's so cheap,
and it's
just
really
eat
quick. It's
yourself
5
out.
minutes. Yeah, I don't know either. I mean, that's above my pay grade. But the lay people, I would be a little cautious of doing that, just because I don't know. I feel like this concussion stuff has already blown way out of proportion, and everybody is talking about concussion, which is good and it's great and all that. But it is a specialty injury, and I feel like people should have at least, you should take like a seminar or something, right? So I don't
Yeah,
want,
like
Joe
VOMS,
Schmo off the
CPD
street.
qualified
yeah,
or
something.
something,
Yeah,
yeah.
maybe that
As a
would be,
part of a whole
yeah,
concussion
that'd
training.
be great.
In an ideal world, maybe.
Yeah, sure.
But I think eye doctors
Yeah,
are
of course.
a great person to do this. I just wish we had more ability to screen for visual issues, because I feel like they're so often missed in concussion.
Mhm.
And everyone knows to put tape on your prism glasses right now, but I sort of feel like that's the crutch without the therapy behind it.
Yeah, we'll pull prism glasses off. Like if we see them, if they come into clinic with prism glasses, we kind of take those off. Not literally pull them off, but we ask them to take it off. I sound like we're just like a bunch of jerks out there, but we're actually very nice people. But we kind of ask them nicely to take their prism glasses off, just because it is like a crutch for them. We kind of want them to expose themselves to kind of functional exposures, because what it is, you kind of, when you live in that kind of life where you're crutching yourself everywhere, you're going to just kind of hibernate, and everything's just going to stay there. And once you try to go to a grocery store, you start freaking out. You may have like an anxiety attack. So we kind of want them slowly to get back into life, and kind of not use these aids, especially with more of the protracted longer term cases. So this is kind of how we think about cases where we work. So we kind of try to, it's not always simple to kind of fit somebody in a box. So there is often overlap between these things. These are the 6 types of concussion, is what we call it: vestibular, ocular, cognitive / fatigue, post-traumatic headache or migraine, cervical, and anxiety and mood. So I'm going to go through these pretty quickly. Am I on time? Okay. So first one, vestibular. It's the sensory system responsible for coordinating your head and eye movements, organizing visual and spatial information, and managing balance function. So there's 2 parts of the vestibular system. The vestibulospinal reflex is the one that you think of when you do balance. So the BESS, the balance test that is often used, kind of measures that. Then the vestibular-ocular reflex is what we're kind of looking for, and that's vision stability, and that's kind of what the VOMS really gets at, especially those last couple, the VOR and VMS portions of it. And symptoms often include dizziness, fogginess, nausea, and environmental sensitivities. The ocular profile kind of looks at the eye, so the convergence really tells us a lot about that. And then the smooth pursuit, saccades, and the convergence are the elements of the VOMS that we're really looking at to see if there's any ocular-motor impairment. And then accommodation is also the other piece of it that we use. So we kind of see, sometimes we see kind of like visual differences between two eyes following head injury, where one eye is kind of seeing clearly here and the other eye is out here. So that's a different type of approach that we take when we refer for therapies. Symptoms, like I said earlier, frontally based headaches, focus problems, difficulty with visually based academics, and they often report like eye pressure, eye pain. Cognitive fatigue, common complaints here, concentration issues, memory, processing speed, fogginess. So this is kind of the classic what people thought of with concussion symptoms of this like cognitive problem, and tiredness towards the end of the day. Accommodations for school really go a long way. If we see an adult who's working, we kind of help them out here too. Give them breaks throughout the day, just kind of break up the day and kind of help them make it through, because we believe having kids in school for as long as possible is kind of helpful and beneficial for them. So if we could build the kind of the supports and structures around them, that'll kind of help facilitate that. And post-traumatic migraine, like I said, this is the #1 symptom that we hear in clinic. And the headaches, the characteristics are headache with close temporal proximity with head trauma, that's a pulsating quality, light noise sensitivity, and sometimes associated nausea with it. And then this, if we kind of get them on that regular schedule for kind of behavioral management with the longer protracted cases, then we may refer to neurology or the headache clinic or somebody to kind of see if there's like a pharmacological portion to kind of help them break the migraine cycle. And then anxiety and mood is the other one. So this is, anxiety has been kind of researched and been shown to be like the most prominent psychological manifestation of this. Can lead to prolonged symptoms. Oftentimes when we see those protracted cases, anxiety is, I don't know exact number, but a lot of the times one of the profiles that we see, and that can lead to kind of exacerbated symptoms. If you're fearful of having a headache, what are you going to do? You're not going to do the things that cause you headaches, right? So you're going to shut your life out, you're going to stay at home, you're going to keep the lights dim, you're not going to talk to your friends, you're not going to exercise, you're not going to do all the things that you generally love to do as an athlete. So with this, I'm trained as a psychologist, clinical psychologist, so this one I try to use my psychology hat and kind of work through that with them. We do very often refer for psychotherapy. We have a lot of people around us that kind of help and know how to address this stuff. And then at times, if we need medications, we will refer to psychiatry if it really gets escalated. Any questions on that? And there is a cervical one, but that's kind of a whole another discussion. That's not really brain, that's kind of a neck from like whiplash injuries. And it's when we ask about headaches, it's important to kind of evaluate what type of headache you're having, because if it's a cervicogenic type headache, it's a different presentation and different type of management than it is from kind of the concussion type headache. So, anything else? All right, so risk factors. This is something that I'm very interested in. It's very fascinating to me, honestly, what you bring to the table and what can result with a head injury. So this is some stuff that's been shown so far. So some pre-injury risk factors, and then some on-field stuff and how that can lead to prolonged recovery. So younger age, migraine history and symptoms, learning disability. We talked about the gender differences, motion sensitivity, and then on-field dizziness. So one would think, right, that if you have a history of migraine, you're going to go down the migraine pathway, And if you have some motion sensitivity, since that is very a vestibular type issue that the brain controls, you would go down the vestibular pathway. But what if I told you family history of migraine has some indications that you're going to kind of have migraine stuff afterwards? So to answer this, Dr. Safrinko is one of our faculty members. She has, she's looked at how family history of migraine can influence post-concussion outcomes measured on kind of the stuff that we use in clinic, neurocognitive testing, symptom report, and the VOMS. So this is the breakdown of the patient group. And then, so she found that people with a family history of migraine were 2.6 times more likely to present with PTM symptoms in the first 2 weeks following concussion. And athletes with post-traumatic migraine experience worse symptoms of worse symptom report cognitive performance and VOMS impairments. But family migraine history did not directly influence symptoms, cognitive or vestibular-ocular-motor outcomes. So it may set the stage for PTM symptoms, but it doesn't directly cause those problems. Any questions on that? And then the next, history of motion sensitivity. So sometimes in clinic when I ask, do you have a history of car sickness? People are like, what? Why are you asking me that question? And I kind of I kind of like narrow it down to know if you're, everybody kind of, you sit in the back seat of a van and you're reading on a windy road, you'll probably feel that's different to me than like if you get, it's very, boats are bothersome, motion sensitivity, all that stuff, then to me that's more relevant than somebody that sits in the back seat of a 12-passenger van and is reading up and down a hill. So this study kind of looked at history of motion sensitivity and how are patients with motion sensitivity more likely to have vestibular symptoms and impairment following a concussion. Again, this was done by Dr. Safrinko, and motion sensitivity was determined with a questionnaire about motion sensitivity and also on the VOMS. So there was two groups, the high motion sensitive group and the no motion sensitive group. And they were assessed about 4 to 5 days after injury. So 1 to 10 days post-injury doesn't, really show that much of a difference between the two groups. And we do kind of see this in clinic where in that first acute to subacute phase, people are fairly higher symptom, feeling it more. But when we look further out into the recovery times, we see the high motion sensitive group showing significant differences across all VOMS measures. And then symptom report, they reported more affective symptoms on the PCSS than the no motion sensitivity group at 1 to 10 days and 11 to 20 days, sorry. But neurocognitive testing didn't have any differences on either one of those timelines. So recovery rates. This is kind of the not the old, but this is the more traditional way of thinking about it. 7 to 10 days, that's kind of the 90% of concussions kind of recover at that point. But when you kind of take all of these factors into account, kind of thinking of it as a heterogeneous injury that has different presentations and symptoms and problems, you would think, right, that this should take a little bit longer. Before it was symptom report and neurocognitive testing, that's kind of what we base it on. But if we kind of look at it, break it up a little bit more, we can kind of see that this actually may be taking a little bit longer than just 7 to 10 days. So this study kind of looked at that, trying to see recovery trajectories using kind of this multimodal clinical assessment approach. So they saw people 1 week in 1 week intervals during the first month following concussion, and they wanted to also check out the effects of gender on recovery across these time periods as well. So 66 high school and collegiate athletes diagnosed with concussion. They completed, again, symptom scales, neurocognitive testing, and VOMS measures. So symptom report overall, diminished over the 4-week period, with the individual week-to-week comparison significant between 1 and 2 weeks, 2 and 3, and 3 and 4. And there's also a difference between male and females at week 2 and week 4. So there was the biggest drop off here from 1 to 2 in both groups, and then it kind of just tapered off a little bit towards 4 weeks. When we look at neurocognitive testing across this timeline, verbal memory showed a jump incrementally, and then significant only from from the first week to the 4th week. Visual memory had differences from 1 to 2, 1 to 3, and 2 and 3. And then processing speed showed improvements from 1 to 3, 1 to 4, 2 to 3, and 2 to 4, as you can see there. And reaction time didn't really have anything but improvements. And as it relates to sex differences in neurocognitive data, there's no significant effect of sex across the 4 weeks on any of the domains. So if you look at these, there's no differences between the two. And self-reported dizziness, which is the left column here, there was a decrease in the report of that from 1 to 2, 1 to 3, and 2 to 3, and the VOMS pretty much all across the board. And when they measured to see who was more likely to be symptom-free at 4 weeks, the males were significantly more likely than females to be asymptomatic by the 4th week, and that's with incorporating all of the stuff that we just went through. I kind of went over this one already. So in conclusion, when you're using kind of this multimodal approach, recovery outcomes kind of push out to the 21 to 28 day period, and then symptoms kind of rapidly, they jump from 1 to 2 and then kind of taper off. Neurocognitive recovery is heterogeneous. Some of them taking about 28 days to recover, some of them a little bit faster, and females overall take longer to recover in certain domains.
Based on that data, what do you think that college level concussion education should say the average recovery time is for an athlete?
Around 3 to 4 weeks on average. That's loose guidelines.
Because I just saw a presentation that came out with the 7 to 10 days thing, and they spent a lot of money doing great athletes, you know, rapping to music, but it was a 7 to 10 day. And
What did they measure on? Was it just...
they said that's the data they were given for the video. But
Okay. I mean, and that's like the $1 million question is, how long does this thing take? I take a case-by-case basis depending on what they come in with, what I think is going to happen. I'll give a loose kind of answer to them if they ask me, but I will definitely don't give firm answers. Again, I give that 2 to 4 week period.
yeah, I think the longer runway just lowers the anxiety of people. So I agree with you. Thanks.
But we do see them fairly often. We will see patients kind of on a week-to-week basis. So if they come back in a week or two and they're fine and they pass all the things they need to do to get cleared, then we'll clear them. So we're not bound to that certain thing.
I think this 7 to 10 versus 3 to 4 weeks, it's because we don't have a valid outcome measure. So, 10 weeks or 10 days for what? For, being symptom free or not having any more brain injury. So if we knew actually what was going on in the brain, we might be able to figure out exactly what we're talking about here in terms of the duration.
Yeah, I mean, that's, I think, what everyone is trying to get at from all angles, honestly, so.
Yeah, I had noticed on one of the prior screens that you had a AD or ADHD component there.
Yeah.
If someone has ADD, how do they track and how does that impact, or does it?
I mean, research is mixed on that too. There is some stuff that shows that ADHD can prolong recovery times. Where we see it the most is in the testing, the cognitive testing. Their scores kind of vary from kind of week to week if you measure them. So one day they'll come in, they'll be doing fine, and then it'll kind of like flip-flop and kind of go all over the place. So there's no definite answer on that as well. There is research that suggests that ADHD and learning disabilities do have effect on longer recovery times, and there are some that say it doesn't. So
And if someone, say a child from early ages through their teen years has had multiple concussions, the more concussions that you have, do you become more prone to getting them easier?
So it's an interesting and good question, a question I get from parents all the time. It depends on how you treat it. So if you come in, we treat you, and if you have headaches, we treat the headaches and they're gone. We're not going to put a football player back to playing football if they're reporting headaches, right? So I feel like where people run into trouble is when they go back too soon, or they're playing when they're having symptoms and they take another blow and it just kind of accumulates on top of each other. That's when I think when they come in and see us, we treat them, we keep them out for however long they need to be kept out. They pass all the things that they need to do to go back. We don't feel they'll have any additional risk where they would have had prior to the first one. And again, we kind of explain, given your history of if you have migraines, you may, have more risk than the other person that doesn't have this problem.
Yeah, I was thinking more that, if someone has had, a severe sports affiliated, concussion, and then has had subsequent ones that were not sport affiliated. Because I know the more you have, the closer sequence, the more damaging it is. But if those sequences maybe are 9 months or a year apart, how is that impactful, or are those relegated as separate instances?
Again, I don't have like a firm answer on that,
Okay.
honestly. So we kind of take it case by case. If somebody gets one and they get cleared, they get another one the week after and they come back, we're like, all right, let's start from ground zero and kind of get this thing under control again. And then if the athlete is like, what about my future? I don't know if I want to keep doing this. I don't know then we have that discussion, and we give them our standpoint on things, and kind of say, hey, it eventually comes down to you, your parents, what you want to do, if there's another sport you like to play. But we kind of take them, treat them up, heal them up, and try to get them back to what they want to do.
Okay,
But,
thank you.
Just a quick clarification. When you talk about giving clearance or return to play, that's beginning return to play protocol, right? Or is that's not like that's beginning return to play protocol, not like being at the full level that you were before.
Yeah.
So okay,
Yeah,
thank you.
yeah. But to get cleared, so the criteria for clearance that we have, just so when people are like, what do I need to do to go back to full games and so on and so forth, asymptomatic at rest, so without doing anything, asymptomatic with physical activity. So we kind of ramp them up, start off, like I said, bike, jog, then you do like sports specific drills. Like if you're a soccer player, we have them kind of do cuts. If they're a football player, they run routes. Obviously no pads or helmet, but we want them lifting weights, all that stuff. No symptoms at that. Then we have what's called an exit test. So one of our PT people will put them through a pretty heavy 45-minute workout where they're really kind of pushing them as hard as they possibly can. They shouldn't have any symptoms with that. The cognitive testing needs to come back to baseline. So we have baseline on the athletes. And no issues with like school and stuff like that. And then that's usually when we kind of sign off on things.
And so that's the 21 to 28 days that you're.
I mean, it varies, but that was just
That's
that
like
one
the-
thing. Yeah,
that's
that
What is
that's
you
kind of what I
expect.
see. Yes,
Okay.
roughly. Depends on how many things people come in with. If somebody just comes in with like one issue, it's easier than people that come in with a migraine and vestibular and anxiety. Then you kind of prioritize treatments and see what's what. Because if you have a vestibular problem and migraines, if I am going to have you run a mile, you're going to feel like crap because you're taxing that vestibular system.
Yeah.
But if you just have migraine or you just have one thing, we can kind of approach it differently. So it does, I mean, the range is, like I said, 1 week to I've seen 6 months. So,
Thank you.
yep.